Good evening, and thank you for joining us for our breast cancer education series on precision medicine, which we are doing in partnership with Memorial Sloan Kettering Cancer Center, Genentech, Integra, and Exact Sciences. We're so glad you could join us this evening, and we're looking forward to a really great discussion. You can see our panelists, Dr. Robert Allen, Dr. Leora Brownstein, Dr. Anita Mamtani, and Dr. Victoria Risk, and they're going to share their perspective on what precision medicine not only means, but what it can do for you. But before we get to that, I want to tell you a little bit about Komen. So as you can see, and as you all know by being with us today, our whole function as an organization is to address all of the impacts that breast cancer has. Particularly as we come out of this pandemic, there have been enormous impacts to the breast cancer community that we're working hard to address. People may not realize that the very basic, most significant risk factors for breast cancer are simply being a woman and growing older, which means that, we have so many people who are affected by breast cancer. In fact, every 12 minutes, someone in the United States will lose her life to breast cancer. We are very focused on the fact that today, unfortunately, African-American women in the US are much more likely to die from breast cancer than Caucasian women. That's about 40% higher. And breast cancer is also the leading cause of death for Hispanic women. So we are making real efforts to address these issues to try and reduce those disparities. Our mission is simple. It's to save lives by meeting the most critical needs in our communities and investing in breakthrough research to prevent and cure breast cancer. So we need to find the breakthroughs that are going to address those deadly cancers, and we need to make sure that everyone has access to that therapy that they need. So what is precision medicine? It's a term that people throw around. People also call it personalized medicine. There's no one real definition, but fundamentally what we're talking about is how we can now come up with very specific treatments and therapies for a person's individual presentation of the disease, rather than saying, okay, you have breast cancer, here's our standard breast cancer treatment. So the kinds of things that physicians will look at when they're trying to understand what can be helpful to you would be things like the tumor biology itself, whether you're hormone receptor positive, HER2 positive, your own genes, and elements that impact your course of your disease, like your lifestyle factors. So the idea is that more and more we're looking at the interaction of all of these factors in an individual person to come up with an individual way to treat their cancer. We just wanted to share a little bit about what Komen is doing in this field and the work that we are supporting financially to try to get at the tools that physicians will need in order to provide precision medicine. So you can see here, we have a lot of work that we're funding in biomarkers, so understanding what factors you can look at and what they tell you about someone's likely course of their disease. And also thinking about, in particular, resistance. So as we know, for example, for women who have, or men who have metastatic breast cancer, they're never out of treatment. So their treatment looks like you start a particular treatment and it works for a period of time, and then the body develops resistance to that treatment and you move on to another treatment. And so if we can figure out how to, in individuals based on their biology and their tumor specifics and other factors, if we can reduce the likelihood that they will develop resistance to a treatment, we can really prolong their lives. So that's an important piece of the work that we're trying to fund. And of course, trying to find new drugs, new therapies that will actually address the cancer cells in these kind of specific areas for a particular person's biology is another thing that we are trying to fund and we hope to get some traction with. we're super proud that we are the organization that has invested more in research than any other nonprofit, and the only organization that has invested more in breast cancer research is the US government. We have been in this work for decades, and we are part of many of the breakthroughs that have happened over the last 30 years. And we know that there are future breakthroughs out there that are just waiting to be made. And what we need is the funding to be able to support those researchers so that they can make the breakthroughs. So one of the ways that we support researchers, obviously, is through raising money. And I would be remiss if I didn't ask you to consider participating in your local Susan G. Komen More Than Pink Walk or Race for the Cure. You can see a list of our events here on the screen. They are both virtual and, in the case of New Jersey, also offering an in-person event opportunity in the fall, and super easy to get involved and a great way to let your friends and family know that this is a cause that's important to you. It's a great way to bring a group of colleagues together or something to do with your friends. Lots of inspiring stories about the people that we're able to help with your support and what we're going to do with the funds that we raise. So very much appreciate it if you would take a look at komen.org to learn more about the event closest to you, and hope that you will participate. So now we're going to get ready to turn over to our panelists. And again, I wanted to share their information with you. We're super excited to hear from Dr. Allen, Dr. Brownstein, Dr. Mamtani, and Dr. Risk. And before I turn it over, I just want to remind you that we do have our virtual sponsor exhibit booths open, and we very much appreciate if you would visit them, because of course we cannot do this work without their support. That's Memorial Sloan Kettering Cancer Center, Exact Sciences, the Integra Foundation, and Genentech. So please do check out what we have at their exhibit booths virtually online. And now, with no further ado, I'd like to pass it over to our panel. Thanks for being with us tonight.
Hi, and thank you for the opportunity to present a talk about breast cancer reconstruction. My name is Robert Allen Jr. I am an attending surgeon at Memorial Sloan Kettering in New York City. I have no financial disclosures. So today we're going to talk about breast reconstructive options following lumpectomy and following mastectomy. And I hope to give you an overview of the techniques and some about the follow-up, and happy to address questions that you may have from the talk in the chat box. Thanks. So first, we'll talk about lumpectomy, and this is when the breast cancer surgeon will remove the cancer without doing an entire mastectomy. And patients have the option for either no reconstruction, as demonstrated here. This is best for patients with small to or medium to large breast and a small cancer that don't desire a breast reduction or a breast lift. And the breast surgeon can do the lumpectomy. Sometimes the plastic surgeon can close the incision, or the breast surgeon can close the incision. And there's no distortion of the breast contour. Patients can then go on to adjuvant therapy, like radiation therapy, which is usually required after a lumpectomy. And you'll note on this patient who had a left-sided breast cancer, a lumpectomy, no reconstruction, followed by radiation therapy, that the left breast is slightly larger than the right, but she has a good cosmetic appearance. And it's important to note that with radiation therapy, that breast will kind of be locked in time. And the breast that does not have radiation can change in size or shape, and the nipple position can change with time. And this may need to be addressed in the future as a symmetrizing breast reconstruction. If no reconstruction is not an option, or if you have larger breast or ptotic breast, you can have an oncoplastic reconstruction. This is better for patients with smaller cancers and larger breast or ptotic breast. And ideal candidates have no history of breast surgery or radiation. These patients desire smaller breast or better positioning of the nipple in the areolar complex. And the options, as mentioned, are breast reduction, as pictured here with the markings preoperatively, or a mastopexy, which is just a breast lift. The benefits of these surgeries are that they're outpatient surgeries. So you go home the same day of surgery, you have a minimal recovery, and you have the ability to preserve the nipple as well as the sensibility to the breast. The downside is that you will have a need for adjuvant radiation therapy following a lumpectomy, and mammograms will still be needed for screening for breast cancers after the surgery, as there's still a significant amount of breast tissue remaining. Additionally, it's a two-stage process. Initially, with the lumpectomy, the breast surgeon or the plastic surgeon will see you the morning of surgery, mark your breast as demonstrated here, and then work with the breast surgeon to determine the best place to perform the lumpectomy through. Once the pathologist have looked at the specimen and determined that all of the cancer has been removed, the patient will return to the operating room 2 weeks later and undergo a breast reduction or a mastopexy. Here's an example of a patient with a right-sided breast cancer. She has some ptosis after childbirth and breastfeeding and desired a mastopexy. She underwent a lumpectomy on the right side. 2 weeks later, she had a mastopexy with a symmetrizing mastopexy on the left side, where we just lift the nipple in the areolar complex. She underwent radiation therapy, and here is her reasonable cosmetic result 6 months following the completion of radiation therapy. Another patient with large ptotic breast with a right-sided breast cancer that underwent a lumpectomy. 2 weeks later, she had a breast reduction and desired significantly smaller breast. She underwent adjuvant radiation therapy, and here's her result at 1.5 years post-op with a reasonable cosmetic result. These patients may undergo changes of the native breast that's not radiated, and so further revision procedures may be necessary. When you have these surgeries, you're going to follow up with your plastic surgeon to be cleared for any radiation therapy. And then you'll likely follow up about 6 months following the completion of radiation therapy to assess your final result. After this, you'll follow up annually or every other year to assess any changes in the breast that hasn't been radiated and the need for any potential revision procedures. Another option following lumpectomy is partial breast reconstruction. This is for patients with small to medium-sized breasts with no desire to change the breast size or their nipple position, and in which a lumpectomy will create a significant contour irregularity of the breast. Options for this include local flaps, such as the thoracodorsal artery perforator flap, the Diap Flap, or the ICAP, the intercostal artery perforator flap. Another option is a free flap reconstruction, taking tissue from somewhere else and transplanting it to the chest for partial breast reconstruction. Here's an example of a 34-year-old woman with right breast cancer, medium-sized breast, and didn't desire any change into the size or the shape of her breast. She underwent a lumpectomy, and 2 weeks later, following negative margins, she underwent a pedicled thoracodorsal artery perforator flap. This is the tissue that we harvested here that we try to hide the scar in the bra line, and this is rotated to the front and placed in the defect of the lumpectomy. Here she is 4 weeks post-operatively, followed by immediately after radiation therapy. You can see the significant changes of the skin. And then 6 months following radiation therapy with a reasonable cosmetic result. If lumpectomy is not an option or a patient desires a mastectomy for treatment of their breast cancer, there are several options for reconstruction. First, we'll talk about no reconstruction, or which has also been called going flat or the aesthetically flat closure. So this is an option for patients, for all patients. Breast reconstruction is not something that you have to do, it is a choice. And some patients want to minimize their recovery time or minimize their trips to the doctor's office, or they want to minimize surgeries. And for some patients, this is an excellent option. The goal of the surgery is to remove the excess breast skin and provide a smooth contour of the chest. Here are two examples, one with just a transverse closure for a patient with smaller breast, no ptosis, and a transverse incision in the chest and a long-term follow-up. And here's a patient with a gull wing type of closure where there is an inverted U for both breast, and they join in the midline to reduce the extra skin. This makes it possible for them to wear a bra prosthesis that they like postoperatively without any redundant skin getting in the way. And here's another option that's kind of between no reconstruction and reconstruction, and it's what's called the Goldilocks procedure. In this procedure, the remaining mastectomy skin following a mastectomy is rearranged and shaped into a breast. And so this patient has no implant reconstruction and has not used a free flap from somewhere else in her body, but we used the remaining mastectomy skin to create this breast shape and did a symmetrizing breast reduction on the left side. We also did some fat grafting to add to contour and the size of the right breast and match the left breast reduction. And you can see her here with her long-term follow-up with a reasonable cosmetic result. For patients that desire reconstruction following mastectomy, there's two main options: implant-based reconstruction and autologous breast reconstruction. Implant-based reconstruction is best for patients that are thinner and they have a low body mass. They have small or non-ptotic breast, or they may desire future pregnancy and not want to have surgery on their abdomen for a breast reconstruction. Patients that undergo autologous reconstruction, where we're using a patient's own skin and fat to shape and reconstruct a breast using microsurgical techniques, are usually patients that have a moderate body mass. They have larger breast or ptotic breast, and they're able to tolerate the potential donor site morbidity required to harvest this skin and fat. So first, we'll discuss the implant-based breast reconstruction. The majority of patients will undergo a two-stage reconstruction. The first stage includes placement of a tissue expander, which is really a skin and a space saver. It's a silicone implant that has a biodimensional shape, can be textured or smooth, and it has a magnetic port finder, which allows us to access it through the skin and add or subtract volume to get the desired size of the breast. This is placed immediately after the mastectomy. This can be placed in 3 different planes: completely under the muscles of the chest, including the pectoralis muscle, the serratus fascia, or even the rectus fascia of the upper abdomen, which is demonstrated here. Or it can be subpectoral, underneath the pectoralis muscle, with an acellular dermal matrix that acts as a sling to hold the tissue expander in place and add to the thickness of the coverage overlying the tissue expander. And more recently, over the past couple of years, there's been a big push for pre-pectoral reconstruction. And this is where a tissue expander is placed above the muscle and can be wrapped with an acellular dermal matrix. Following the first stage, patients will come to the clinic for tissue expansion, usually 3 to 4 times. And once healed and done with adjuvant therapies, they'll return to the plastic surgeon, usually 3 to 4 months later, for planning of the second stage. During the second stage, the tissue expander is removed, a capsulotomy is performed to release the capsule that surrounds the implant, and a permanent implant will be placed. The patient is allowed to heal. 3 to 4 months later, they return. If they're happy with the size and the shape of the breast, they'll move on to nipple reconstruction or nipple tattooing as their final stage. There is an option for a 1-stage breast reconstruction with implants. This is called direct-to-implant reconstruction. The benefit of this is to undergo a mastectomy and a total breast reconstruction in 1 stage. Like the 2-stage process, these implants can be placed under the muscle, subpectoral, or above the muscle, with or without the use of an acellular dermal matrix. Here's a patient of mine that underwent 1-stage breast reconstruction. She is multiple years out from her initial procedure and had a subpectoral silicone implant placed following a nipple-sparing mastectomy. You can tell with subpectoral placement, the pectoralis muscle will retract and can pull the nipple and the areolar complex superiorly laterally. So this is one thing that you'll want to discuss with your plastic surgeon. Following up with the plastic surgeon for implant-based reconstruction is on a weekly basis if you're undergoing tissue expansion, and then 3 to 4 months in between procedures to allow for recovery of the body and the patient and the resolution of postoperative edema. And then following total reconstruction, you'll visit with your plastic surgeon on an annual or every other year basis. And this is for routine screening to follow our results and to address any issues that may arise with time. Finally, we'll discuss autologous breast reconstruction. And this is where we take skin and fat from one area of the body and we transplant that to the chest. Using microsurgical techniques, we're able to attach blood vessels that supply the skin and fat from other areas of the body to blood vessels in the chest. And as long as blood is going in and coming out of the tissue that we transplant normally, then it will survive. This is a long-lasting breast reconstruction and is desirable for many patients. The Diap Flap, which was first described for breast reconstruction by my father back in 1989, is the gold standard for autologous breast reconstruction. The Skin and fat of the lower belly is harvested based on blood vessels that come through the rectus abdominis muscle. And this tissue is then transplanted up to the chest where it's attached to the internal mammary vessels. Here's an example of the exposure of the internal mammary vessels in the chest. They are quite small, and so we use a microscope to suture these blood vessels together. Here's harvesting of the Diap flap. In this case, the blood vessel went around the rectus abdominis muscle. We save all of the muscle and all of the nerves to maintain abdominal wall strength for these patients postoperatively. And here's an example of the fascia that we close following harvest of the Diap flap. Here's our long-term result of this patient following one revision. You can tell that she's got a reasonable cosmetic result and improvement of her abdominal wall contour. All patients are not candidates for Diap flaps, whether they have previous abdominal surgeries or they have a paucity of tissue of the lower belly. And so I'll show you now a couple of alternate options for autologous breast reconstruction. This is a patient with a genetic predisposition to breast cancer that underwent profunda artery perforator flaps. This flap takes skin and fat from the posterior thigh, and her example is in a diagonal orientation, and the scar comes along the posterior thigh. It can also be oriented transversely under the buttock crease to better hide the scar. And here she is at her long-term follow-up following nipple tattooing with a reasonable cosmetic result. Another option is the lateral thigh perforator flap. This is best for patients that have a saddlebag deformity of the thighs, and we aim to capture this extra skin and fat of the lateral thigh, and we transplant that to the chest for a breast reconstruction. Here's this patient 1 year postoperatively following removal of her tissue expanders with a reasonable cosmetic result and improvement in her donor site contour. Another option is called the lumbar artery perforator flap. This flap takes advantage of the love handle deformity that can be seen on some patients and takes the skin and fat of the lower lumbar region of the lower back and transplants that to the chest for reconstruction. This patient had previously undergone a Diap flap for her right breast and unfortunately developed a contralateral breast cancer. She was referred to me to discuss further reconstructive options. And after evaluating her, she underwent a lumbar artery perforator flap. And here's her immediate postoperative result. Another option are gluteal-based flaps. These are flaps based on blood vessels that come through the gluteus maximus or the buttock muscles. This patient had a left-sided breast cancer, developed capsular contracture, and wanted to use her own tissue and remove her implant. She underwent a gluteal artery perforator flap for left breast reconstruction. We replaced a lot of the lower skin, which was contracted in her, and did a symmetrizing right breast reduction. Here's her long-term follow-up with a reasonable cosmetic result of both the breast and of the donor site. And in some patients, one flap is not enough. And so there is an option for stacking flaps where we take multiple flaps from different parts of the body. In this instance, this is a young lady with breast cancer that underwent stacked Diap flap and Pap flaps for breast reconstruction. We took the lower abdominal skin, and we also took the posterior thigh skin and used 2 flaps for each breast to reconstruct following a nipple-sparing mastectomy. Here she is after one revision, 9 months after one revision with a reasonable cosmetic result and improved contour of her abdomen and posterior thighs. In conclusion, breast reconstruction is a personal choice. Every patient does not have to undergo breast reconstruction. If they do choose to undergo breast reconstruction, there are many different ways to do this, and choosing the best option for you is a decision that you should make with your reconstructive surgeon. It's important to remember that breast reconstruction is a process. It entails usually multiple surgeries and entails time to go and see your reconstructive surgeon. And this process takes time and may take multiple surgeries to reach the final result. So thank you very much for your attention. It really has been a pleasure to present to you, and I look forward to answering any questions that you may have had. Thank you.
Hello, and thanks for joining us for today's discussion of precision medicine in breast cancer. I'm Lior Bronstein, a radiation oncologist and program director at Memorial Sloan Kettering Cancer Center, and I'll be reviewing a few concepts of precision radiation in early stage breast cancer. So in thinking about contemporary breast cancer management, it's important to recall where we came from historically. Breast cancer was a recognized disease dating back to ancient Egypt, with historical accounts over millennia documenting the mastectomy, which was a long-standing and often disfiguring approach to treatment. And for centuries then, breast cancer treatment largely relied on increasingly aggressive maneuvers to remove the breast and surrounding tissues. These days, however, with improved imaging and surgical approaches, breast conservation is an effective option. And you'll sometimes hear this called a lumpectomy. Those terms are interchangeable. And in the lumpectomy, that essentially allows the tumor to be removed in its entirety while preserving the breast itself. But as the lumpectomy and breast conservation became possible and began to supplant the mastectomy, a series of trials were conducted to evaluate what to do about the rest of the breast that previously would have been removed with mastectomy but was now left behind. It was unclear if that was a safe approach, and so a major clinical trial essentially compared recurrence rates for lumpectomy versus lumpectomy followed by radiation to the breast. And they found here that at 20 years after treatment, patients who underwent lumpectomy alone had about a 40% chance of recurrence in the breast, while those who received radiation had only about a 15% chance of recurrence in the breast, thereby cementing the benefit of radiation after surgery. Further refining this approach, in recent years, we've learned that breast cancer is not just one disease entity, but actually several different types of cancer, each with its own risk level, represented here by the different colored lines. And for comparison, the gray line here represents a subtype called HER2-positive breast cancer that used to be among the most aggressive, but is now very effectively managed with targeted therapy. But in comparing that gray line to the luminal A subtype represented by the red line, the difference in recurrence rates over time actually becomes quite striking. And when outcomes are as good as we see on that red line, essentially just a 1 to 2% chance of recurrence 6 years after treatment, we start to wonder if we can dial back the treatment somewhat and perhaps do away with radiation for these luminal patients. And so this is a clinical trial that's currently ongoing in the radiation community using a molecular test called PAM50 to identify all breast cancer patients with the luminal A subtype and enrolling them on a study where they don't receive any radiation after a lumpectomy with the hypothesis that they'll do just as well and potentially spare them this extra treatment after surgery. Now, remember the gray line that I mentioned a moment ago that showed the HER2-positive subtype of breast cancer. Here's an example of how those patients do today with targeted anti-HER2 treatment. And so this was a trial giving HER2-positive patients just 2 effective drugs, paclitaxel and Herceptin. And it showed that after 7 years, those patients who used to do the worst actually now have a 98.6% chance of having no recurrence 7 years after treatment. And so now they exhibit among the best outcomes as far as breast cancer subtypes. Now, for those patients who still require radiation, we have some novel techniques that help to reduce the chance of side effects and make the treatment a little bit more precise. And here what you see is a CAT scan showing the breast here, and in colors showing where the radiation is going as it traverses the body. Now, we can interpret these treatment plans much as you would interpret a topographic map as looking at elevation of a hill or a mountain when you're out for a hike, with each successive colored line showing an increased dose of radiation. Now, this structure here in the center is the heart, and you can see that the heart is very close to the breast and receives some radiation here when the patient is breathing freely. Now, in the right-sided panel, we monitor the patient's breathing and ask them to perform what's called a deep inspiration breath hold, which we coach them through. And you can see that the heart in the center of the chest is now further away from the breast and does not receive any radiation as exemplified by those lines and the topographic map. And so that's a very common technique that's now employed in order to protect the heart from the radiation that needs to target the breast. In addition, there are a number of treatment planning innovations that help us to target a given tumor. And so these are examples of a head CT with a brain tumor colored in red that's being targeted. And so starting on the top left, you can see the historic treatment approach with 2 radiation beams that traverse the entire head and administer high-dose radiation along a stripe to reach the tumor. And the warm colors here represent the higher dose regions of radiation, and the cooler colors represent lower dose regions of radiation. So as you progress to the right, looking at the image on the top right, additional beams have been added from different directions to create a more conformal treatment. And so that's represented by the warm colors now fitting tighter around that red structure, which represents the tumor target, and the cooler colors are now a little bit more spread out. The ultimate level of precision, though, is shown there on the bottom right with a form of radiation called proton radiotherapy, which can be shaped very effectively to avoid normal structures around the tumor. And there you can see that the warm colors very tightly hew to the red, which is the tumor target, with very few areas of cool colors that might otherwise be exposing the normal tissue surrounding the tumor target. So another example here, these are some breast plans that we can look at. And the ones on the left and the middle show different X-ray techniques. And these have been the conventional forms of radiation and continue to be for about 99% of patients who receive breast radiotherapy. And on the right is a proton treatment. And you can see that the colored area representing where the radiation is actually going on the right side with the protons is very much limited to the chest wall towards the outside of the body and spares the heart, which is that central structure, which in the other two X-ray forms of radiation otherwise receives a little bit of radiation, and that's largely unavoidable based on the properties of X-ray radiation. So as it happens, proton facilities are few and far between, with only about 25 or so throughout the United States. And this is one of the newer centers in the country. This is the New York Proton Center. And we certainly do employ it when there are appropriate cases that require proton radiotherapy for breast cancer, where otherwise the heart would be getting an inordinate amount of radiation with other techniques. And as with most things in medicine, we try to conduct trials to advance the science and ensure that we're treating with the best possible approaches. And so this is an ongoing trial called RADComp, which is being conducted nationally and is essentially designed to compare X-ray or photon radiation to proton radiation. And we'll be looking at the long-term outcomes of proton radiation to see if it's safer from a cardiac standpoint in terms of reducing side effects related to the heart in the long term. And so these days in breast radiation, we routinely conduct biologic subtyping to evaluate risk. Most patients are able to avoid mastectomy and have breast conservation. And our medical oncology colleagues employ newer targeted therapies. And our own techniques like protons are also much more conformal. And that all leads to improved outcomes and more limited side effects in a precision medicine approach to the localized treatment of breast cancer. So that's just scratching the surface on innovations in breast radiation. There are new advances almost monthly, and I'm happy to field any questions as they come up. Thank you.
Hi, my name is Dr. Anita Montani, and I am a breast surgeon at Memorial Sloan Kettering Cancer Center. It is a real pleasure to speak with you all today on the subject of precision medicine in current breast cancer treatment, particularly how this pertains to breast surgery now in 2021. Please feel free to ask questions as we go through, and I'll be happy to answer those along the way. As a general introduction, as many of you may already know, the surgical treatment of breast cancer has evolved dramatically in recent decades. There was significant morbidity, risks, complications associated with the traditionally more drastic surgeries that we used to perform decades ago. However, over the recent years, we have learned a lot more about the cancer tumor biology, and we can now better tailor and individualize our therapies to each patient. The result is that now we can do less drastic surgery with no compromise to our cancer outcomes, but a significant reduction in the morbidities associated with the surgeries that we do. So today I'm going to take you through the process of surgical breast cancer treatment, starting from initial treatment evaluation, then the surgery planning, and then the actual details about the surgery done on the breast and the axilla. A breast surgeon will oftentimes be one of the first physicians that you see after receiving the diagnosis of breast cancer. The initial evaluation that takes place is a time of information gathering, a time that we're trying to learn everything that we can, all the data points that we need to make a treatment plan. This involves learning more about both the cancer, but also about the patient. For our evaluation of the cancer, we really have three main tools, the first being history and exam. We try to learn from the patient what symptoms they have noticed themselves, as well as the timeline and the progression of those symptoms. This is done in conjunction with a thorough exam, and the most common things that we are looking for are masses, either in the breast or in the armpit, changes to the nipple, such as inversion or discharge, any skin changes, as well as change in shape, size, and even feel to the breast. The next tool that we utilize for evaluating the cancer is imaging. Mammogram, which you can see on the top right here, is often the starting point for most patients' workup. Other tools that are also often used will include things like MRI, ultrasound, and all of these tests are really helping us to visualize the cancer, to see it, as well as understand the size, the extent, and the location of this within the breast. And all of this is very important, of course, to clarify when making the surgical treatment plan. Then we also rely heavily upon pathologic diagnosis from a needle biopsy. This is required not only to confirm the diagnosis of breast cancer when you see an abnormality in the breast, but also for us to learn more about the type of breast cancer. This also includes learning about the receptor status. This is something that we also refer to as the subtype or the profile of the breast cancer. And what we are trying to learn is the estrogen receptor, progesterone receptor, and the HER2 status. All of this is very crucial for us to understand the biology of the tumor and how we can best treat it. Finally, we also, of course, want a very complete evaluation of our patient as well. We take into account factors such as the patient's age, their comorbidities or other health concerns, any risk factors that they might have for breast cancer, as well as their particular family history, potentially also utilizing genetic testing if a patient meets certain criteria for this. Now, the reason why all of this information matters is that we know very clearly that not all breast cancer is the same, and of course, not all patients are the same. So it is of the utmost importance to integrate all of the information that we can gather about the cancer and the patient and create the best possible surgical plan. So this brings me to the next portion of the process. Once we have completed that initial evaluation, we move over to planning the actual treatment itself. Timeline, I think, is something important to discuss. Even though a surgeon might be the first person that you consult with, surgery is in fact not always the first step. There are generally two approaches for patients with non-metastatic breast cancer. One is called upfront surgery, which means we do go ahead and do the surgery first. And this is generally the advised approach for many early stage breast cancers. The alternative is something called the neoadjuvant approach, where we actually give medicine first and then follow with surgery later. This is a more useful approach for patients with more advanced cancers, such as those with larger tumors, those who might have positive lymph nodes, etc., as well as certain subtypes of cancer. The decision on whether to do surgery first or whether to give medicine first is something that is a joint decision, often case by case, made between the surgeon, the medical oncologist, as well as, of course, the patient. When the time does come for surgery, whether that is upfront or after medicine, the preoperative process involves sort of routine pre-surgical testing, medical clearances to make sure that a patient is fit to receive anesthesia and to actually have the surgery. And then comes the surgery itself. The surgical treatment of breast cancer involves two components. We perform surgery both on the breast to address the cancer within, but also perform surgery in the armpit, otherwise known as the axilla. The reason for that is that the majority of the lymphatic fluid within the breast drains to the lymph nodes located in the axilla. If a cancer is trying to spread out of the breast, the most common pathway is to go through this lymphatic chain. And this is why lymph nodes are involved in our surgical treatment process. I will first start by discussing surgery of the breast. There are generally two types of operations that we perform. One is breast conserving surgery, otherwise known as lumpectomy, and the other is mastectomy. So how do we choose which of these operations to perform? A number of factors are taken into account here, and you will see that a lot of this comes from that very detailed initial evaluation that was done. Is the cancer early or is it advanced? Where is the tumor located? What is the size? What is the extent of it? What is the patient's family history? What are other relevant patient factors, such as their age, their comorbidities? And of course, what is the patient's preference in all of this? While some patients medically do require a mastectomy, some patients with early stage cancers are actually a candidate for either breast conservation or mastectomy. A large body of research over the past 30 years has proven that survival outcomes are equivalent after either lumpectomy or mastectomy for patients with early stage cancers and with similar low rates of local recurrence. Among those who do choose breast conserving surgery, the process involves a quick same-day procedure which entails removing the tumor along with a clear margin of normal breast tissue around it. At times, the tumor can be felt with our fingers, but other times we might not be able to feel the tumor if it's too small. In those cases, a guide of some sort is required for us to know which area exactly is to be removed. At Memorial, we use seed localization for this purpose. There are these tiny radioactive markers that are placed before the surgery, and then during the surgery, the cancer as well as these markers are removed entirely, as shown in that X-ray on the top right. The incision is placed in a cosmetically desirable location, and after removing the cancer, the breast tissue is rearranged within so as to maintain a nice appearance to the breast. After lumpectomy, many patients have a relatively quick recovery process, generally being entirely recovered within 1 to 2 weeks. As I mentioned a few moments ago, mastectomy is the other surgery that we can perform on the breast, and there are times where a patient may medically require a mastectomy, such as when the cancerous area might be too large to remove with a lumpectomy, when the disease is multicentric or scattered throughout the breast, when patients cannot have radiation after lumpectomy, or simply patient preference and other individual factors. Decades ago, the traditional radical mastectomy used to be quite invasive. However, nowadays, we have actually many different ways in which we can perform a mastectomy, and overall the procedure itself, as well as the long-term recovery, have become much less morbid. As shown here, the types of mastectomies we now perform include the modified radical mastectomy for more advanced cancers, as well as the commonly used skin-sparing mastectomy and nipple-sparing mastectomy approaches. The choice of which type of mastectomy a patient might be eligible for is, again, an individualized decision depending on the extent and location of the cancer, as well as the risks and benefits for that individual patient. After a mastectomy, the recovery process includes achieving pain control, regaining and maintaining mobility of the arms, managing surgical drains that are left temporarily in place. And generally, most patients have a recovery process that lasts anywhere from 4 to 8 weeks. Next, I will shift gears to talk about the axilla. We have 2 types of procedures that we perform in the axilla, and this is all done at the same time as the breast operation as well. These 2 procedures are the axillary dissection and the sentinel lymph node biopsy. Axillary dissection was historically actually performed for all breast cancer patients. This involves making an incision in the armpit and removing all of the axillary lymph nodes that are located in the lower part of the armpit, as well as behind the pectoral muscle, which sits on the chest. Now, there are some risks associated with removing all of these lymph nodes, the most common ones being lymphedema, or a chronic arm swelling that occurs in about 20% of such patients. Additionally, there are risks of limitations to arm or shoulder movement, lymphatic cording, as well as chronic numbness that can happen. Now, while this procedure is in modern times still required for some patients with more advanced cancers, we do make a concerted effort to avoid performing axillary dissection whenever at all possible. This has been made possible by a much less invasive option that we now use routinely for many cancer patients. This is the sentinel lymph node biopsy procedure, which is done for those who have no abnormal lymph nodes that we detect on our preoperative evaluation. How we do this is by injecting a tracer or a dye into the breast that travels into the lymph node chain, and it allows us to identify the initial or the sentinel lymph nodes. This allows us to then evaluate and test just a few of the patient's lymph nodes for cancer without needing to remove all of them unnecessarily. Again, of course, there are still some situations where patients might require a complete axillary dissection, but the use of this sentinel lymph node biopsy procedure has made that a relatively less common occurrence than it was in the past. Finally, I will also share that there are some situations where we do not perform any surgery in the axilla for select patients. There is research that has shown that this step can be safely omitted in some patients, specifically those who might be elderly or have significant other medical issues. And I think all of this comes back to that original concept that we started with of precision, that not one size fits all. And along the way, we really do try to tailor our choices to each individual patient that we are seeing. So now that I've taken you through that whirlwind tour of breast surgery, I will summarize by saying that breast surgery has truly evolved dramatically in the recent years. And the concept of precision is really key in everything that we do, how we screen patients, how we diagnose cancers, how we treat cancers. At the end of the day, the ultimate goal is to individually tailor treatment to our patients, to decrease the morbidity and the burden of the surgery that we do, yet also achieve and maintain those excellent cancer outcomes that we strive for, ultimately to improve the quality of life of our cancer survivors. So thank you all for listening, and I look forward to taking any more questions and chatting with you all further. Thanks.
My name is Victoria Risk. I am a physician who works at Memorial Sloan Kettering Cancer Center, and today we're going to talk about breast cancer and precision medicine. A couple of the questions we're going to answer today is, what is precision medicine? Also, how does precision medicine impact patients? What is taken into consideration when making a treatment plan? And how does this affect prognosis and follow-up? So I'd say the biggest question is, what is precision medicine? Precision medicine is personalized treatment. And what that means is that all over the world, we've been giving treatments for certain diseases in kind of a one-size-fits-all approach. So if you have high blood pressure, you just get blood pressure medicine. If you're diabetic, you get diabetic medicine. But when it comes to cancer, it's pretty unique. And every cancer has its own set of mutations, its own set of receptors, its own set of biomarkers that help us figure out why it happened and how we can treat it. So instead of doing that one-size-fits-all approach, we can actually tailor customized treatment plans for each patient and try to make it a little bit more specific to the person and their cancer. Breast cancer is actually one of the first cancers to be treated that way. Back in the day, they figured out that most breast cancers have estrogen receptors, and some have a receptor called HER2/neu. Most breast cancers have a combination of estrogen, progesterone, or HER2/neu. And sometimes all three of those things can be negative. But those aren't the only things that we figured out about breast cancer. So over the last 20 years, we've been able to figure out what are some other explanations for why these cancers happen and what drives them. From a genetic standpoint, we've been trying to figure out how we can impact patients who have BRCA1 or 2 mutations. And we'll get into why BRCA1 or 2 mutations are important and what that means. So how does precision medicine impact patients? And that really depends on the type of breast cancer you have, the staging of breast cancer, and the type of biomarkers that your breast cancer expresses. So for early stage breast cancer, and that's ER/PR positive, meaning your estrogen receptors are expressed and your progesterone receptors are expressed, gene expression assays provide prognostic and therapy predictive information. And so what that means is you're going to end up, or patients end up going to surgery, they send a sample to a lab and they run a 21 gene assay. The preferred assay that is available right now is called Oncotype Dx. And the reason for that is it's been proven to have prognostic and predictive value. So we can really figure out who needs chemotherapy and who doesn't. We used to give everybody chemotherapy who had lymph node positive disease. Now we don't do that. We used to give chemotherapy to everybody who had a large tumor, and now we don't have to do that. We're really able to figure out who requires chemotherapy and who doesn't. And that helps us identify who's going to benefit and who won't. So then you're not ending up with a lot of toxicity from a treatment that you may or may not need, and it gives us a little bit more guidance to help our patients. On the other hand, if you have advanced or metastatic breast cancer, we're still able to customize those patient plans as well. And ultimately, that allows us to guide therapy decisions and match patients to relevant clinical trials. And we can do that through genetic testing and molecular profiling. So MSK specifically has a test called IMPACT, and that looks at over 300 genes, looking at your specific DNA. So everybody was born with a certain set of DNA, and that doesn't change over time. It is what it is. Some people are born with mutations like BRCA1 or 2. Some people are not, and they don't have any mutations. So where does cancer come from? After that point, we are able to look at the cancer's DNA and say, okay, maybe the mutations are there. And by doing that, we can actually look at the cancer itself, figure out the mutations, and find out what happened along the line to make this cancer possible. And now we know how to treat it. So once we have that information, we're able to tailor each person's treatment plan based on the mutations that are there. So here's an example of some targeted therapies and biomarker testing for specifically stage 4 breast cancer. Any kind of breast cancer, any subtype, any stage, we do the genetic testing if you're a candidate, and we look for BRCA1 or BRCA2 mutations. We do that doing germline sequencing, which is what we just talked about, looking at the DNA of each individual person and figuring out if they were born with this mutation. If we do figure that out, then there are a lot of surgeries that can be done to prevent breast cancer and ovarian cancer, but also there's a treatment that's available if or when they're diagnosed with breast cancer that we can give on the back end to help decrease their risk of it coming back. And those medicines are called olaparib and talazoparib. On the other hand, if you're HER2 positive or HER2 negative, HR positive, and you have a PIK3CA activating mutation, and we can test for that using PCR, then there's another FDA-approved agent called alpelisib, and we join that with a medicine called fulvestrant to help decrease patients' risk of progression at the time of diagnosis. So a last option, or another option, is triple negative disease. That's one of the most aggressive and hardest to treat types of breast cancer. So we want to make sure that we're at least giving those patients as many opportunities and options as we can. So you've probably heard of immunotherapy for other kinds of cancer. We don't typically use immunotherapy for breast cancer that's estrogen positive or HER2 positive. But for triple negative breast cancer, now we have the option of being able to include immunotherapy to help with that kind of treatment. And specifically, we look at the biomarker for PD-L1 expression. And depending on the percentage of PD-L1 expression, you might be a candidate for a medicine like atezolizumab and Abraxane, or pembrolizumab and chemotherapy. And those medicines have been able to give people durable responses. And what I mean by that is you can go months to years without ever seeing your disease progress or it causing any problems in your body. And so these options are actually the best that we can offer for patients who have these specific mutations or expression of these certain receptors. So what exactly is taken into consideration when we're making a treatment plan? We look at a lot of different factors. So we look at patient features and we look at cancer features. The most important is obviously the patient features. We look at comorbidities, anything like diabetes, obesity, hypertension, heart failure, you name it. We got to look at it. We got to make sure that you don't have any other underlying condition that might put you at risk of any increased toxicity with any of these treatment options. We look at performance status. We want to make sure that you're able to get up and walk around and be strong enough to handle whatever treatment we have available for you. Another important thing specifically for breast cancer is menopausal status, because that has a big impact on how we treat our patients. If you're premenopausal or postmenopausal, you're going to be a candidate for different treatments. Genetic testing, again, very important. That gives us some information on BRCA status and other underlying mutations that might put you at an increased risk for other kinds of cancer. Environmental factors, we want to know where you've been, where you hang out, what things you're exposed to, because that might impact toxicity from the chemotherapy. And other lifestyle factors are also very important. If you drink alcohol, if you use any kind of drugs, what kind of lifestyle do you have, and is there anything in it that might impact your treatment? Cancer features are also important. We also look at the stage, the subtype, the receptors and biomarkers, Oncotype testing, any genetic assay that might be available to you, and as well as molecular profiling. So combining patient features and cancer features, we're actually able to make treatment plans that are much more precise than just saying, okay, you have breast cancer, here's the treatment. We're actually able to say, here's your stage, here's your subtype, these are your receptors, and this is the type of treatment that we would recommend based on those things. And how does this affect your prognosis and follow-up? Your prognosis and quality of life is significantly improved when we're able to tailor your treatment to you. If we're able to target a treatment specifically to you and your breast cancer, then we're able to allow for a more effective treatment with less toxicity because it's actually targeting the exact mutation or target that treatment that we want. It's not a situation where you're just getting a blanket drug like chemotherapy, which kills healthy cells and cancer cells. So in this situation, we're able to actually use these medicines to target specifically mutations that cancer cells have and that you might carry. And in doing that, we can prevent as many side effects, and we can allow for people to live better, healthier, happier lives without feeling sick or like they need to be in the hospital because they're not feeling well from the treatment or the disease. And personalized treatment allows for personalized follow-up. So depending on the type of treatment that you get, you'll be able to have a customized plan of how frequently you need regular blood work, scans, and follow-up. Almost all of these treatments do require some blood work, some scans, and follow-up, but that frequency is going to be based on the specific patient, their stage, and their treatment. Do you have any questions? Thank you.